Can you unshare for a minute? You are able to, we are able to see you. I will just. Dr. Sindhuja, are you with us?
Yes, sir.
Can you switch on your video, ma?
Yes,
Faculty.
sir. Am I audible, sir?
We are yet to wait. Let me. Yeah, we are able to see. Can you just unshare for the moment, ma? Introduce the
Yes, sir.
session with us.
Yes, sir.
Can you switch on your video, ma?
Yes,
Faculty. Warm welcome to all the faculty and the students. Today we have two important exam cases. One is a case of parotid tumor, other is a case of ventral incisional hernia for discussion. We have two eminent faculty, Professor S.P. Gayatri ma'am, HOD Stanley Medical College, Professor Prabhakar sir, HOD Chettinad Medical College has joined as faculty. And I also thank our own faculty, Professor Rajiv Sahai sir, Professor Hitesh Andarya sir, Dr. Srinivasan sir, Dr. Nishikan Gujar, and other senior people who have been with us for the past 6 years. And now we have two students kindly contributed by Professor Karan sir, Medical College, Dr. Sindhuja, and Dr. Hitesh Andarya sir has kindly contributed Dr. Vedan Shah from Narendra Modi Medical College. I warmly welcome Professor Abhay sir for this session. Good evening, sir. So, friends, without much ado, we start the first presentation. First presentation will be by Dr. Sindhuja. The second will be by Dr. Vedan Shah. Sindhuja, please unmute yourself, introduce your unit chief, your head of the department, and start your presentation. Good luck to
yes,
you.
sir.
All the best.
Thank you,
Faculty, please take over.
Thank you, sir. So, good evening, all the dignitaries who are joined for the session today. And I am Dr. Sindhuja, second year postgraduate, General Surgery Department from Madurai Medical College. And my chief is Dr. K. Saravanan, Professor in HOD, Department of General Surgery, Madurai Medical College. So, shall I start the presentation, sir?
Can I make it full screen? Make it slideshow.
Yes, sir. Sure, sure.
Yes. Good luck to you, ma. All the best.
Yes, sir. Thank you, sir. So, chief complaints. It's a 60 years old housewife, Mrs. X, hailing from Madurai, came with chief complaints of swelling below the left ear for about 6 months. History of presenting illness. The patient was apparently normal 6 months back when she noticed a swelling below the left ear, which was insidious in onset and initially small in size and was gradually increasing in size. There is a history of sudden increase in size of the swelling in last 1 month. It is also associated with pain over the swelling for the reason 1 month, and there is a sudden onset, and which is a sudden onset, non-progressive, dull aching type, radiating to the appear, no aggravating factor, and relieved on taking medications. So there is no history of increase in size of the swelling while chewing food or food intake. No history of pain while chewing the food. No history of any fever. No history of any discharge. No history of any pus discharge in the mouth. No history of restriction of mouth opening. No history of dysphagia. And there is history of asymmetry of face for past 1 month. There is history of deviation of the angle of mouth to the right side for past 1 month. And history of difficulty in closing the eyes on the left side for the 1 week. And no history of drooling of saliva from the mouth. And no history of loss of appetite or loss of weight. And no history of dryness of the eyes, mouth, or any joint pain. And no history of any other swelling in the opposite side of the face, neck, or anywhere else. and there is no history of trauma. And past history, no history of similar complaints in the past. She's a known diabetic for almost 5 years, for which she is on OHS, taking metformin. And she's a known case of hypothyroid for 5 years, and she's on L-Troxin. No history of radiation exposure. History of appendectomy 25 years back. There is a nil significant family history and personal history. Patient consumes a mixed diet, normal bowel and bladder habits, normal sleep and appetite, no history of betel nut chewing, no history of smoking or tobacco chewing, no history of alcohol consumption. And obstetric history is P3L2 and no relevant menstrual history. And summary, a 51 years old lady presented with a swelling below the left ear for 1 month with a history of sudden increase in size and pain over the swelling for 1 month. And according to the history, it is suggestive of the facial nerve involvement. Probably it might be a case of malignant left parotid swelling. Shall I proceed to the examination, sir?
No. We'll get your history first, Dr.
Yes.
Sindhuja.
Yes, sir.
Okay. What was the size? Let's go to your first slide.
Sorry, sir.
What was the size when she first noticed?
Sir, initially it was around 2 centimeters in size, sir. And now
You
it
can
is
mention it. You can mention it, saying that as just showed by the patient, that it
it's
was about 2
as
centimeters.
told by the patient, sir.
Yeah, so you can put that there. And what's the size now?
It's almost around some 5 centimeters to 6 centimeters, sir, 5.5.
Okay, so in 6 months, it's almost 3 times. Sudden
sir.
increase in size.
Yes, sir.
Did she have pain in the ear first, or the nerve involvement first, or did she have pain, sudden increase in size first? Just go to your first slide, please.
She had a history of increase in size
No,
first,
just
followed by
Dr.
which she
Sindhuja,
had a
Dr. Sindhuja, let's go to your first slide, please.
yes, sir.
Slide by slide, we will discuss. Go back to your first slide.
Yeah, that's it. Next slide. Next slide, please. So, and she had pain. So both the swelling, increase in size and swelling appear together.
No, sir. Initially, there was increase in size of the swelling, followed by which
1
she
month.
had pain.
And an associated pain was swelling for 1 month. So both occurred together.
But both occurred at the same time, sir. But initially, she noticed an increase in swelling first. After that, only she started perceiving pain.
So after how long did she notice that there was pain?
Almost
And
after
look,
2 weeks, sir.
so that should come in your history, no? We want to
Yes.
know, like, uh, when was the nerve first involved, right?
Okay, sir.
Next slide, please.
Yes, sir.
And when did she get this this involvement of facial nerve?
Sir, it is been
Other
there
than,
for the past 10 days, sir.
so next slide. Look, you've given us negative history, and then you're going next slide, please. Now you're giving us history of ACID. This should come before,
Yes, sir.
isn't it?
Yes, sir.
Involvement of facial nerve is a very important feature.
Yes.
You can't place it right down right towards the end, right?
Okay, sir.
So this should come above, before the slide. And then negative history. What's the negative history?
Sir, no history of
So all this
associated.
should come. Yeah, all this should come in the next slide.
Yes, sir.
Okay. Okay. Why do you take history of trauma? No history of trauma you've taken. Is it important here?
Yes, sir. Any history of trauma, the patient may, followed by which the patient may have parotitis, any inflammation, or any hematoma
No, look,
collection or abscess.
look, Dr. Sindhuja.
Yes.
This is a MS exam, postgrad. You've written no history of fever. Then why take history of trauma, parotitis? Do you get me?
Yes, sir.
You've got no features of inflammation here.
Yes.
And history of trauma, why? I mean, how does trauma help you? It doesn't. It's just just because it's written in the book, you don't write it here, isn't it?
Okay, sir.
Okay. Next slide, please. Past history. Okay, next slide, please. Next slide, please. No, just you said no history of just go back, please. History of diaphragm history. Okay. There's no history of drooling of saliva in spite of deviation of mouth. Unlikely. Okay. Next slide, please. Okay, next slide. Okay, all this hypothyroidism, this is medical history. It's not past history, right? You've got a section called medical history, and that's where it goes. Like if she was diabetic, she's past history diabetic, doesn't have diabetes now. She has got. It can't be a past history, isn't it? So it's got to be medical history. Family history, nil significant. Why? Are there any ones which run in the family?
Conditions like Sjogren's and Mikulicz may run in
Mm-hmm.
families. Autoimmune
Excuse me?
conditions like Sjogren's and Mikulicz can run in families.
Okay, that's good. Okay, next slide, please. Yeah. Next slide. Okay. Right. Thank you. Anyone else, sir, please?
Sindhija,
sir.
yes, madam. Sindhija,
Yes, sir.
go back to the first slide. My way of dealing with the student. Yes. Yeah, 60-year-old female. Isn't it? In this age group, 60-year-old age, which tumor is common? Benign or malignant?
Malignancies are more common, and
What?
malignant
What is
transformation of benign condition is also common.
But in this patient, the tumor is present or the swelling is present for how many months or how many years? Patient
6
noticed.
months. 6
Only
months.
6 months. Okay. 6 months. Madurai, chief complaint of swelling below the left ear. What do you mean by below the left ear?
Below the left
Below
ear
the left
lobes.
ear, angle of the mandible, or in the clavicle, which region?
In the mandibular region, sir. Behind the
Angle of the
mandible.
mandible,
Angle
or near the mental process.
Yes.
Okay, right. Next slide. What would be the
Sir,
reason?
Prabhakar sir,
Yes, madam.
can I also join along with you?
Yes, madam. Please join.
The patient says below the ear, but you know this is a parotid swelling, and you know the location of the parotid, and when you see also, you know the swelling is in and around parotid, right? All around parotid.
Yes, sir.
So you can always say, even if the patient is going to say it is below the ear, you can always say she came with a swelling in front of, below, and behind the ear. So
Yes,
that
sir.
the examiner knows what you're trying to present. As
Yes, sir.
Prabhakar sir said, it can be anything. Below
Yes.
the ear means it can be anywhere until the foot also.
Yes, sir.
Do you understand?
Is
Yes,
So
sir.
the patient has told this, but you know very well it is a parotid swelling. So you can always say the patient came with this.
Yes,
You
sir.
can modify it a little.
Yes, you can say in the parotid region.
Yes,
Yeah,
sir.
that
Say
is
it
true.
is in the parotid region. That's it.
Yes.
That is
So you
correct.
needn't say
Terminology.
exact words of the patient.
Okay.
You should
Sindhija,
understand and tell it to us.
Yes, sir.
what are the borders of parotid region? Every professor is telling about the parotid region. What are the borders of parotid region? Superiorly, inferiorly, anteriorly, and posteriorly. What is parotid region?
So
The swelling
superiorly,
is present inside that parotid region. Yes. Superiorly,
the parotid region superiorly the
posteriorly from
inferior
the
border of the zygote. Inferior border of the sarcoma, and behind by the mastoid process, and below by the angle and ramus of the mandible, sir.
superiorly zygomatic process, posterior of, then below angle of the mandible.
Mandible.
Anteriorly, posterior border of one muscle. What is that muscle?
Sir?
Masseter muscle.
Yes, sir.
Then posteriorly,
Mastoid,
external acoustic.
external
Addus
acoustic,
and
mastoid.
mastoid, all these things. This
Yes.
is the region of the parotid. Okay.
Parotid. Yes, sir.
We have elicited the history of first discharge in the mouth.
Yes, sir.
They are suspecting some swelling in the below the ear. Why are you asking for the first discharge in the mouth? Mouth means oral cavity. Which part of the mouth you are asking?
Sir,
discharge,
if the,
whole mouth.
if there is a form, if there is inflammatory conditions and there is duct obstructions due to stones, there may
In
be
the floor
pus
of the mouth, is
discharge.
it? You're talking about the floor of the mouth.
Yes, ma'am. Near the
Yes.
opening of the duct. Opening of the
Then
duct.
you should be more specific, no?
Yes, ma'am.
Where it
Near the
opens, parotid.
above the third molar, sir.
Huh?
Above the third.
Upper,
Third molar.
third molar.
Lower
What is
or upper?
Upper third molar.
third
Third.
molar? You are second year MS student from Madurai Medical College. I am giving one clue. Second year.
Parotid duct.
Huh?
Parotid duct.
Opposite the crown of the what
Crown of
molar?
the. Yes, ma'am.
See, again
Second
and
molar.
again we are saying, is it third? Is it third? That means it is a clue. Sir has also
Second
given you a very good clue.
Second molar.
Opposite
It's, it opens in the upper surface of the crown of the upper second molar, sir.
Yeah. Yes.
Okay. Then you said
Restriction of the
about this
mouth
pain.
opening is called
Sorry, sir.
Restriction. What is this restriction of mouth opening called?
Trismus.
Then why didn't you say that? When you can say dysphagia, why didn't you talk about trismus?
what could be the reason for trismus in a case of swelling in the parotid region?
In case of malignant tumors, it may involve the pterygoid plate, which may cause trismus.
Temporomandibular joint.
Yeah, TMJ joint.
Messenger. What are the four muscles of mastication?
Masseter, buccinator, pterygoid, sir.
Vaccinated.
Masseter, pterygoids.
Medial pterygoid and lateral pterygoid. Then your Madurai is very famous for temples. Meenakshi Amman temple. One clue. The fourth muscle.
Or
Temporalis.
temporalis.
Four muscles. Okay. Right.
Which muscle will help in the opening of the mouth?
Sir Jailal sir, good evening, sir.
Good evening, sir. You are giving a big clue of temple, but she is not able to pick up. What is among these four? Which is the muscle responsible for opening the mouth?
Pterygoid.
There are two pterygoids, ma'am.
Lateral pterygoid.
Okay. What is the origin? What is the incision? What is the nerve supply of the pterygoid muscles? So when you are presenting parotid, it is mandatory. You must know the nerve supply of all the muscles of mastication. This anatomy you need to go, you can read. Go ahead, sir.
How the dysphagia can occur in a case of parotid swelling in the jaw?
It is actually it is less likely, sir. When due to restriction of the mouth opening up, the patient may feel difficulty in swallowing, sir.
Restriction.
But per se dysphagia is unlikely.
Deep lobe of the parotid is enlarged.
Pushes something medially.
Then muscle.
That's only malignant conditions with a deep lobe involvement.
Which phase of the deglutition is involved?
Sir?
What are the phases of deglutition? What are the areas where you can get dysphagia, or what are the process at which you can get dysphagia?
The areas of esophageal constriction, sir.
Okay.
Where it causes the cricoid.
Okay, sir. I think
Okay.
he's finding it a little difficult.
Okay, next slide. Asymmetry of the face. What do you mean by asymmetry of the face? In which condition you can get the asymmetry of the face, ma'am?
Facial nerve palsy, sir.
Facial nerve palsy. The patient is having deviation of angle of mouth on the right side, but difficulty in closing the eyes on the left side. How? What is the concept behind that?
Sir,
One
in
is on
case
the
of
physical
element
and
palsies,
Huh?
it's a Bell's phenomenon, sir. In case of element facial palsy, there will be deviation of the mouth to a normal or healthier side, sir.
the
Due to
tumor
the
is present in the left
over-contraction
side
of
or in
the
the right side? Tumor is present in the
left side.
left side. But the patient is having deviation of the angle of mouth to the right side.
It is due to the
How?
contraction of the healthier side of us, sir.
Which nerve is involved for angle of mouth deviation? There are 5 branches of the patient now. Tell
Yes,
me,
sir.
what are the
Mandibular. Margin mandibular.
from above downwards? You please tell me from above downwards.
Temporal,
The basic thing
zygomatic,
is first 2 branches. Basic
temporal
2 branches
zygomatic,
and then
buccal, marginal mandibular, and cervical branches.
Okay.
No,
Among these 5 branches,
Dr. Sindhu, sorry, sir. It divides into 2. What are the 2
Mm.
branches of the facial nerve?
that's
main
true.
2 branches.
Temporofacial and
Temporofacial and
cervicofacial.
yes, sir.
Cervicofacial. And,
Cervical.
right? Yeah. And then it has those 5 branches. Now tell
Okay.
us the branches.
Yes.
Which muscle is supplied by this nerve? Which muscle angle of the mouth?
Orbicular is sir.
Huh?
Orbicular
Arbitrary?
is
Any other muscle?
buccinator, sir.
Orbicular is
Buccinator.
for the deviation of the angle.
Depressor muscles, angles. Labia, inferior, angularis. Like that. Okay, right.
Then Sindhuja, you said there is history of difficulty in closing the eyes on the left side for 1 week. Yet the eyes are not dry. It's not watering, nothing. Do you get it?
Sorry, ma'am.
Even for a few minutes, if you keep your eyes open, they become dry and they start watering, right?
Yes, ma'am.
I have missed something there, right?
Yes, ma'am.
Okay, go to the next slide now.
In which condition you will have dryness of the eyes?
It is Sjogren syndrome and Mikulicz syndrome, sir.
No.
What is Sjogren
What is the
syndrome?
difference between these 2, Sjogren's and Mikulicz?
Mikulicz, it involves the salivary along with the lacrimal glands, sir.
Okay.
Whereas Sjogren is associated with dry eyes, dry mouth, xerostomia.
That is also from the salivary gland.
Yes, sir. But it also involves other systemic disorders like vasculitis, purpurine, and
That
other
is
rheumatoid
depends upon
arthritis.
if it is the primary Sjogren or Sjogren syndrome.
Sjogren syndrome.
What is the pathology difference between this
Lymphocytic infiltration, sir. More than 50% lymphocytic infiltration of the gland will be there, sir.
That will be there in both the condition. What is the antibodies
Lymphocyte
will be there?
infiltration is more predominant in Sjogren, sir.
No. Which antibodies will be there?
ANA will be there.
It's not an antibody. Which is reversible, which is not reversible. So what is the cause for
Mikulicz is not reversible, sir.
Which one?
Mikulicz.
Not reversible. What is the cause for Mikulicz?
It is secondary external factors influencing, sir. Sjogren's is autoimmune, sir, so it is irreversible, sir.
Yeah, that's fine. So Mikulicz is due to? So Mikulicz can be reversible.
Yes.
There is no apoptosis. There is no antibodies will be there.
Yes, sir.
Okay, go ahead.
The patient is having tumor.
Sorry, sir. Not able to.
Parotid region in the left around the audible, madam Sindhuja?
And now it's okay, sir.
Okay. Why you elicited the history of joint pain in a case of swelling in the parotid region? Ear pain means it is understood. Unnecessarily you ask joint pain and all. Why?
In case of Sjogren's, there will be triad of this dry eyes, mouth, and rheumatoid arthritis will be there. So to rule out that history, I have included the joint pain also.
Rheumatoid. Okay.
Yes.
No issue of any other swelling in the opposite side of the face, contralateral side of the face, neck
Yes.
or so. What are the
Yes.
commonest causes for bilateral swellings of the parotid?
As said now,
Glands.
Mikurick's Sjogren syndrome, Barthen's may be bilateral, sir. Then some cases of sialadenitis and HIV-induced sialadenitis, sialidiosis, in these conditions, it may be bilateral, sir.
In pediatric age group, commonest cause for bilateral enlargement of the parotid glands? One viral infection.
Mumps, sir. Mumps.
Okay, no issue of trauma. Yeah, hematoma. Okay, right. Next slide.
So even this pain, I'm not convinced about the pain in this patient. The description she has given. Dull aching pain, then radiation to the ear, then what is that, during chewing, nothing is happening, no aggravation and all that.
What are painful parotid swellings, ma?
Parotitis, or viral etiology like mumps and sialadenitis.
Sialadenitis. Then parotid abscess.
Parotitis.
Any other malignant swelling which will start with the painful swelling?
Yeah, pleomorphic adenoma turning to malignancy.
That is a
When the
pain
benign
at the
swelling
site.
getting
Those are the
transformed to malignant swelling, there will be pains, sudden onset pain will be
Yeah.
there.
All those pains will be felt at the parotid. But
Yes.
you said there's a pain in the ear. Why there is pain in the ear?
So it's due to the referred pain, sir.
How?
So most commonly the auricular temporal nerve, it also supplies the EAC, external auditory canal also. So also there is involvement of the middle ear.
Auricular temporal supplies the parotid?
I send secretomotor fibers to the parotid also, sir.
Okay. From there?
It also supplies the middle ear also, sir. So the pain is most commonly perceived in the middle ear.
Should we go to the examination, sir? I think we've done half an hour.
Yes.
Yeah, please. Dr. Sindhya, please.
Yes, sir. General examination, sir. The patient is conscious, oriented, afebrile, moderately built and nourished, and vitals are stable. And there is no pallor, ictus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. This is the clinical picture of the patient, sir.
You said in the history there is asymmetry, in the photo also asymmetry. The general examination, you are not talking about that asymmetry. That is the most striking feature when you are seeing the patient.
Yes, sir.
As a postgraduate, we are not saying to the routine. What we are seeing, obviously, the first thing is an asymmetry is there, obviously.
Yes, sir.
We are putting conscious, oriented, all that is not necessary in a full sense. Because unconscious patient, we are not going to give you for an examination.
Okay.
But what is significantly present in this patient, you should notice and it should present in the case.
Yes, sir.
Okay.
So an inspection and ill-defined swelling of size 4 class per centimeter approximately noted in front, below, and behind the left ear, lifting the earlobe and filling the retromandibular groove. So almost hemispherical in shape. It's extend anteriorly up to the tragus and posteriorly up to the mastoid process, and is external auditory meatus superiorly to the angle of mandible inferiorly. Surface appears to be smooth and skin over the swelling appears normal. The swelling lies deep to the deep fascia, at a superficial to the masseter muscle, and no other swelling on the opposite side of the neck. So deviation of the mouth, see, and examination of the facial nerve. Facial asymmetry is noted. Wrinkling of the forehead absent on the left side. Difficulty in closing the left eyelids. Angle of mouth is deviated to the right side. The patient is unable to whistle or blow. Left nasolabial fold is absent.
Yes, go ahead.
Yes, sir.
Continue.
Yes.
Simple examination, you finish it up. Oh, video.
And on palpation, there is no local rise in temperature. Mild tenderness present over the swelling. And all the inspectory findings are confirmed by palpation. The surface is smooth. Skin over the swelling is pinchable. It's hard in consistency. Borders are ill-defined. and not mobile. Curtain scene could not be assessed. And temporomandibular joint is not involved. And oral cavity examination found to be normal. Examination of the oral cavity, mouth opening is adequate. There is no erythema, no discharge, no medial displacement of the tonsil. On bimanual palpation, the enlargement of the deep lobe is noted. By digital palpation of the parotid duct, no palpable stones, no dental caries, or no halitosis. Examination of the neck, there is no enlarged cervical lymph nodes noted. And examination of the other side, the contralateral right parotid gland is normal. And examination of the other salivary glands are also normal. Systemic examination is normal. The probable diagnosis, a case of malignant swelling of the left parotid gland with ipsilateral facial nerve involvement. Probably could be T4A and 0N0, sir.
Okay, I think you've done a wonderful job, Dr. Sindhuja. Very good. Okay, just you don't say bimanual oral examination. You can't put your whole hand inside. It's bidigital in both the sides, right?
Okay.
Just
How
go
will you
to
palpate
palpation, please.
the parotid duct? How will you palpate the
Yeah.
parotid?
Sir,
Look.
one index finger should be placed inside the oral cavity, above the crown of the second molar, and other thumb outside over the cheeks. So we have to roll it over the masseter. We can feel the duct, sir.
How do you know which is masseter?
Sir,
How do you know it is masseter which you are holding? What are the layers of the
you can ask
cheek?
the patient to clench.
Can you see that buccal region? What are the from the medial to lateral? What are the layers?
Sorry, sir, I couldn't get you.
From the mucosa side to the skin on the buccal region, what are the layers you get?
Mucosa,
Inside
muscle
out.
layer.
Inside
What are
out.
the
Have a mucosa. What is next to the mucosa?
Submucosa will be there. Then
Submucosa. Oh.
muscle layer,
Straight
masseter
away
will
muscle
be
layer
there,
will
sir.
come.
Masseter, and then the gland, then comes the gland.
There is two muscles are there now, that region. Buccinator is there, masseter is there.
Duct will be there over the masseter, sir.
Which is outermost
It
or
moves.
innermost?
Sir, superior to the masseter.
No. Which is superior in the lateral side, buccinator or masseter?
Duct will be superior, masseter.
So it is not
No,
that.
he means the two muscles, which is lying over the over
From
the other one.
outwards, masseter will be superior, sir.
Right. So that's why it moves on the masseter, then pierces the buccinator, and then
Yes,
moves inside the mouth. Okay,
Yes, sir.
goes submucously from the third molar, which you said, but it opens over the second molar.
Second.
It starts
What is
its
the
submucosal course
surface
at the
marking of
third
the
molar,
insect?
and opens in second.
For
What
that,
is
you
the
need to
surface
put the
marking?
masseter into contraction, and then you have to roll over, not just
Roll over
holding it.
the duct.
And you can't do that by that method. Okay. Go ahead.
Okay.
So there are two methods of examining the duct. One is you roll over, other you make it taut, and then you
Clench
can
it.
feel the thing, or you do a bidigital, right?
Yes.
You do a bidigital and you can feel it. So there are two ways, either bidigital or by rolling over the contracted
Yes.
masseter.
What is the surface marking of this parotid duct? Sindhuja.
Sir, sorry, sir.
Surface
What is
marking
the surface marking, ma?
of parotid duct. Do you have an idea, Sindhuja?
Not sure, sir. It's
So give you hints from the angle of mouth to the tragus, divide into three parts. Any idea?
From the tragus to the angle of the mouth, you have to draw a line, middle 1/3. Okay, that is the surface marking of the parotid
So you
duct.
do-
What is the name of the parotid duct?
Stenson's duct, sir.
What is the length of that duct?
Not sure, sir.
5 to 7 centimeter. Okay. What is the name of the submandibular gland duct?
Martin's duct.
Where it opens?
In the floor of the mouth, on either side of the frenulum, sir.
On either side of the
Middle and frenulum.
frenulum of the tongue. Okay. What is the name of the sub?
Pattern.
Gland, sublingual.
Okay, sublingual
Where it is
duct.
present? Flora of the
Sublingual
mouth.
gland ducts.
Where it opens? What is the name of that duct?
Sublingual pattern.
Bartholin's duct or duct of
Yes,
Redius.
sir.
Okay?
Yes, sir.
Yes. The flora of the mouth. Okay, right. Dental case.
What is your intention of doing bimanual palpation?
To know the enlargement of the deep lobes, sir. So in intraorally, we can
How do
see
you
that the
palpate it?
tonsillar fossa is pushed medially, sir. In case of deep lobe enlargement, so we
Ma,
can.
it is only an inspective finding. You cannot bimanually palpate for the deep lobe. And also you have said no erythema, no discharge seen where?
in
No erythema, no discharge seen where?
so around the opening of the duct and in the tonsillar fossa.
But it is not written there.
In the tonsillar fossa also. Why?
Erythema and discharge is seen only around the opening of the duct. No?
Okay, that you have not mentioned.
Yes.
Hmm.
In what way the
Okay,
dental caries is important, ma'am? In the case of parotid, why you have looked for the dental caries? In the case of parotid swelling, the upper second molar tooth, dental caries, that is that tooth caries. What will happen? In
The
that
pus-
area only, the parotid duct opens, isn't it? So
Yes.
sometimes it may get infected, ascending
Yes,
infection. Okay,
infection.
right.
Yes.
The enlargement of the deep lobe. How will you know that? Enlargement of the deep lobe?
Intraorally, there will be a medial displacement of the tonsillar fossa, sir.
That can be even due to the tonsil.
Then how can you say deep lobe is enlarged? You cannot even see it, no? Even palpation, how do you know that is a deep lobe? Bimanual palpation, no. It is always an inspectory finding.
Okay.
It's very difficult to put your finger there in the tonsillar fossa.
Yes, ma'am.
Okay?
Okay.
So it's always an inspectory finding.
Yes.
What
Okay,
is
shall we go to the next slide?
Yes. Next slide.
Okay, so do you think the cervical lymph nodes will be enlarged in a case of parotid malignancy?
Yes, ma'am.
So which one?
Which group of
Which malignancy?
Lymphatic spread involved from the intraglandular to
All the types of malignancies go to the lymph nodes?
deep cervical may be involved, ma'am. Finally,
Ma, see,
submandibular, after that deep cervical nodes, level 2, 3
I
nodes.
am asking you one question and you are giving me another reply. I said, do all the types of parotid malignancies metastasize to the lymph nodes?
No, ma'am.
No, that means which one goes and which one doesn't go. Anything is fine.
The high-grade variants like squamous and adenocarcinoma, they are more prone for a lymph node maximum.
So you're talking about squamous cell carcinoma of the parotid, adenomatous carcinoma of the parotid.
Mucoepidermoid carcinomas.
We are talking about parotid gland tumor.
Yes.
So which
What
carcinoma
about the lymphomas of the parotid?
Adenocystic lymphomas.
Adenocystic carcinoma goes or not?
No, ma'am.
Less, it goes less to the lymph nodes.
Yes.
Okay. Actinic cell tumor also doesn't go.
Yes, ma'am.
Whereas lymphoma can.
Lymphomas.
Okay.
So,
Yes.
what is the
Okay.
what is
So that is why you look
commonest-
for the enlarged lymph nodes.
yes.
what is the commonest
Oh.
malignant tumor of the parotid?
Malignant
Sindhuja?
mucoepidermoid carcinomas.
Mucoepidermoid carcinoma. What is the commonest benign tumor of the parotid gland?
Pleomorphic adenomas.
What is the commonest second benign tumor of the parotid gland?
Barthel's.
Warthin's. Warthin's tumor. Okay, mucoepidermoid.
Dr. Sindhuja, you said that the curtain sign could not be elicited. Did you?
Yes.
Just go back to your slide, please.
Yes,
Hello.
sir, she said.
Yeah.
Curtain slide. Curtain sign
Yeah, curtain sign
Curtain
could not
sign.
be assessed. So, first of all, what is curtain sign? What is the importance of curtain sign? And why do you think it couldn't be assessed?
So curtain sign is it's related to the mobility of the tumor in the parotid. So the vertical movement will be restricted above the zygomatic arch. It is because the deep
That's fine,
fascia.
that's fine, that's fine. It's okay. So, what's the importance of this? Curtain sign?
The tumor is confined. It does not breach the deep fascia.
No.
There is no
It is to
extra
distinguish between, it is to distinguish
These
swellings
deep
which are superficial to
parotid
the,
swelling from the other
right,
lymph node
from the
swellings.
swellings which are superficial to the deep cervical fascia,
Yes, sir.
right? Right. Now, why do you think this could not be assessed? You said couldn't be
Because
assessed.
in this patient, clinically, the swelling is not typically seen in front of the trachea, sir. It is just below and behind the only, sir.
Any other reason? I mean, even if it's lying in the lower lobe, we can still push the parotid. A normal, benign parotid swelling can still be pushed up, can't it? It's got that much mobility.
How will you quantify the curtain sign?
I think there are 3 grades, sir.
If you cannot go beyond the zygomatic arch, then you say it is a curtain sign is positive.
Yes, sir.
That means it is below the zygomatic, within the investing layer of the deep fascia. It is not.
Yes.
So you cannot say could not be assessed.
Okay, sir.
Right? You just
Since
say
you
You
that
try and say it is not
it is
possible.
negative.
That's all. Nothing
You
say
just
negative.
say that
Okay,
it is negative,
Negative. Yes, sir.
right?
Yes.
That means why do you think it's negative? Because it could be fixed to the surrounding tissue.
Yes, I just meant to say that
It's
it
not
is
mobile.
negative only, sir.
Have you written anything about mobility? You've written not mobile. So
Yes.
obviously,
Yes, sir.
obviously, that's the reason, right?
Okay, sir.
Sindhuja,
Okay.
in your case, the earlobe is lifted or not
Yes, she said lifted.
Yes, sir.
lifted? Some of the conditions of the parotid swellings, you cannot expect the lifting of the earlobe. What are those conditions? But it's a parotid tumor. Are you able to understand my question?
Yes, sir. Yes, sir.
Yes, please tell me. In some of the conditions of the parotid, you cannot expect the earlobe to be lifted. What are those conditions? Though it's a pleomorphic adenoma, though it's a malignant swelling of the parotid gland, I'll tell accessory parotid gland, over the
Yes,
central steps.
sir.
If any tumor arises from that, can you expect the earlobe to be lifted? No.
No, sir.
Then deep lobe involvement, pleomorphic adenoma of the deep lobe. Will it lift the earlobe?
No, sir.
No. Apex of the apical region of the parotid gland, that is pyramidal shape, isn't it? In
Yes,
that area, here, is there any tumor? Will it lift the earlobe? No.
sir.
Isn't it? Yes.
What is that accessory parotid gland?
Social parotid.
The accessory gland is present along the duct, sir.
Along the duct. So it has a same duct.
No, sir.
In which condition? Benign condition or malignant condition you get?
Benign.
Body consistency, surface is smooth. Your patient is a malignant swelling, you are telling that, but the surface is smooth. How it is possible?
The skin is also pinchable. So where it is fixed?
And below the deep fascia, sir.
Through the deep fascia.
Swelling lies below the deep fascia. It's not fixed to the skin, sir.
So investing layer is a deep fascia or not?
Yes, sir.
Okay. What do you mean by it's below the deep fascia?
I'm sorry, sir. It's below the parotid fascia. I want to say. It's not fixed to the skin. That's why skin pinchability is mentioned.
Okay. No. Why the movement is restricted?
Movement is restricted because of the curtain signs, paper. The gland is enclosed by the incision of deep cervical fascia, so thereby the mobility
There
is
will be
restricted.
always you can move. That is why we say we can go move up to the sagoma arch.
Yes.
Now, in this condition, you are saying because your surface is smooth and your skin is
And
pinchable.
also,
As fixed to the underlying masseter, maybe
it has got a
underlying
regular
muscle
border,
fixation.
is it? You've not mentioned about whether it is irregular border or not.
The borders ill-defined only.
Ill-defined. What about
Defined and
regularity?
irregular also. Borders are irregular only.
So ill-defined doesn't mean it is irregular.
Okay.
Dr.
Okay.
Sindhuja, another
Yes.
thing which I find is a problem in your history examination is that you said it's not mobile, but to what structure is it fixed to?
That
You've
is what
not
you are
mentioned
asking.
that, right? Because that's an important finding or examination which is going to direct your treatment.
Yes.
Is it fixed to the bone? Is it fixed to the muscle? Is it fixed to the skin? Right? So
Yes.
that you have to do. That is glaringly absent in your examination.
Okay.
Okay.
In which type of parotid swelling you will have basilated surface, ma? Parotid swelling. Surface is basilated or nodula. In which type? Or in which pathological lesion of the parotid gland you will get basilated surface?
Warting.
What is the difference between nodularity and basilated? Any idea?
Nodularity, yes. Nodule, there will be intermediate normal tissue will be there, sir. Between the
Within
nodules.
2 centimeter diameter, that is nodular
Size.
surface. If it is
Size.
more than 2 centimeter, it is basilated.
Basilated.
Yes. In pleomorphic adenoma, you can get basilated surface.
Basilated.
Like that in breast phylloid tumor, typical surface is basilated. Okay.
Yes.
Okay, right.
Just also.
You have put
Okay,
the
doctors.
temporomandibular joint not involved. How did you examine the temporomandibular joint?
So we can insert the little finger into the external auditory canal and then place the pulp of the little finger medially. So ask the patient to move open the mouth. We can assess the movement of the temporomandibular joint and we can measure the interincisor distance.
That is that
You know,
will
Dr. Sindhuja, there's an easier way of examining the TM joint, right? First, you palpate both the sides and see whether they're moving equally. Then the mouth opening would be restricted if the TM joint is involved,
Yes.
right?
Yes.
So if there's no mouth opening restriction in mouth opening, if it's normal, then the TM joint should be free of any disease, right? So okay, let's go back to this. How do you know your tumor is fixed to the masseter or to the underlying bone?
We can ask the patient to clench the mouth, sir. On contracting the masseter, the swelling will become more prominent
So
if it is
because
not
you're
fixed.
okay. If the thing is totally not mobile, what do you think it's attached to now?
Masseter attachment will be there, sir.
No, masseter you can
Bone
still move. It's a
involvement may be
muscle,
there. Bone involvement
right?
may be.
So obviously, now is it moving with when you're opening the mouth? Is it moving with the movement of the jaw?
Not to mention, it was moving while moving the jaws.
Okay. Should we go to the management, sir?
Yes, sir.
Okay,
I will
Sindhuja.
manage this patient.
Quick. We've got 20 minutes now for management.
Yes, sir. From the history, there is a pain and swelling is up. It's hard in consistency and it's fixed. And also there is involvement of the facial nerves, sir. So also with age, the lesion is more in favor of a man.
Look, Dr. Sindhuja, you've come out with this already staged it, T4A N0 M0. So you've presumed it's malignant. Now what?
So we have to proceed with ultrasonogram of the parotid region, sir. And followed by
Okay,
which
what
you
are
have
you
to do
looking
a
for in
FN.
ultrasound? What are you looking for in ultrasound?
The extent of the tumor we can assess and the origin of the tumor, where the presence of any nodes.
No, is 4 centimeter, is the size important in head neck tumor?
Yes, sir, for staging.
No, why is this 4 centimeter cutoff important?
Staging of the tumor, sir.
Anything over 4 centimeter has a poor prognosis.
Poor prognosis. Yes.
Right. Yours is 4 centimeter or could be more.
Yes.
Right?
So
So obviously the size is such. Right. Okay. So ultrasound, you see the tissue of origin, the size.
Yes.
What else?
Yeah. Any presence of any lymph nodes, sir.
Very good. What else?
The tumor components, you can say the cystic and solid.
Yes,
and
whether
mixed
it's solid or
components, sir.
cystic, right?
Solid.
Okay. So,
Then we have to
sir,
proceed.
please. So you've done an ultrasound and it says that there are no lymph nodes, like you said, but the tumor is about 4 centimeters. It is heterogeneous. Now what? Any role for FNAC?
Yes, sir. We have to go for FNAC to confirm the diagnosis, sir.
What is
Why
the
not?
grade?
Points in favor for FNAC, points against FNAC.
In this case, all the points are in favor of malignancy, sir. So,
No, why do you want to go in for FNAC?
to have a tissue diagnosis, sir.
Why do you want a tissue diagnosis? Does your management change?
For the treatment, sir, we want to know whether any lymph as per invasion.
No, does your management change?
Yes, sir.
Your deep lobe is not involved. You got no lymph nodes. It's 4A, but fixed to probably the bone. Look, there's no harm in doing an FNAC here now because the nerve is already involved,
Yes, sir.
right? It is fixed to the underlying tissue.
Yes, sir.
Right? There's no harm in doing an FNAC, right?
Yes, sir.
But generally, Parotid, why don't we do an FNAC? Suppose we have a
To
benign tumor.
differentiate between benign and malignant neoplasm. So when we are
Suppose it was a benign tumor, there was no nerve involvement. Would you go in for an FNAC or not?
yes, sir.
You know,
Usually,
grading system of
origin.
FNAC for parotid? What is
Yes.
Milan's grading?
So Milan's grading for a FNAC of the salivary gland tumor, sir. First one is grade 1 is a non-diagnostic, and then inadequate non-diagnostic benign lesions, neoplasms of benign origin, and there is a ATP of undetermined significance, and the salivary gland tumor of undetermined malignant potential, suspicions of malignancy, and it's a malignant tumor, sir. Sir, in first
good.
2 grades, we have to correlate clinically, sir.
No, Dr. Sinha, hang on. That's fine. Now, you tell me whether in a benign condition you will go for an FNAC or not.
Yes, sir, still we can do FNAC to confirm the
No,
diagnosis.
so you can do anything. Usually we don't do an FNAC. Why?
We don't. If it is suspicious from the history wise, we can go for FNAC. If it is
Look, I'm telling you, suspicious from the history again. I'm telling you it's a benign condition. No facial involvement. There's no lymph nodes.
If no needs, if no nerve involvement, nothing is there for benign condition, no need of
What is the practice, in your department? Will you do FNAC for a parotid or not?
we are doing.
We are doing. No, it is.
Okay.
Just in doing.
Okay, you can do it, but usually what is the treatment for benign parotid tumors? It is superficial parotid. Your FNAC report will not change your treatment, right? In fact, FNAC can result in hematomas and damage to facial nerves. You may require an ultrasound guided, all that kind of thing, and doesn't change. So usually people don't, unless there is a strong suspicion that there may be something other than a benign tumor.
Yes.
You get me?
So what is the purpose of doing here? Because the nerve is involved. In which kind of parotid tumor the nerve will be involved? What histology will be show the nerve involvement more? You said the commonest malignancy is mucoepidermoid. Will the mucoepidermoid produce a nerve involvement?
Mixed malignant
No, sir.
tumor of the parotid gland will go through the perineural spread. Perineural spread is common. In which type of malignancy of the parotid gland?
Squamous and
Uh, I will give 3 options.
We just spoke about it. Ma'am just told you about that lymph node, which tumors don't go through the lymph node. She mentioned something about passing through the nerves. Adenoid cystic, okay?
Adenoid cystic lymphoma and actinic curve.
So
Right.
what is that?
That's
There it
why-
is not sufficient. You do only a superficial parotidectomy. You
Yes.
should do either radiotherapy or other additional measures has to be done. So that
Yes.
is why FNAC is being considered as a factor, because that's not stops. What you are thinking is a malignancy, your treatment is not going to stop with the superficial parotidectomy.
Yes.
That is why adenoid cystic has this bad habit of coming back after years of surgery.
Recurrence. Common.
Yeah, very common.
Yes.
Okay, so you've done an FNAC. What did you have the FNAC report here?
No, sir. I haven't included in
No, do you
this.
have the FNAC report, Dr. Sindhuja? Okay.
It's not
Suppose
included
it
with the
turns out to be a adenoid cystic. Now what do you do?
How do you
management, sir.
proceed? Yeah.
No, investigations
Any
So
other
we have
other
to
than
investigations
do
you want to do?
FNAC. Other than FNAC.
In this case, we have to do CT, sir, because possibility of bone involvement is there. So we have to do CT.
Which bone you're talking about?
Mandibular involvement.
How do you know that the mandible is involved?
The swelling is very much restricted now. It's fixed.
You thought the parotid swelling will keep moving around like a fibroadenoma?
No, ma'am. It moves along when the patient opens the mouth also. Ma'am.
How do you know that it is fixed to the mandible? You want
From
to
the
know
site
if it
of the
is
tumor only.
what is it?
Based on the location of the tumor only, ma'am. It's just
So you
about
thought it is. So you thought it is fixed to the mandible. Where else it was fixed? Only the mandible?
Yes, ma'am.
See, we don't know. Clinically, we will not know.
The purpose of taking CT is to know the
Ah.
deep lobe involvement.
Yes.
So
Any
Surrounding
extranodal
structure
is
involvement. Infiltration into the surrounding
extraglandular
structure.
infiltration. To look in
And
the
Okay,
also
that is why you
when
want
the
to
pterygoid
CT.
gland, when it is involving the pterygoid fossa, it is becoming
Yes, sir.
inoperable tumor.
when involves parapharyngeal spaces also,
Parapharyngeal
we have to
spaces.
do CT.
Here
What
the
are the structures you will remove in radical parotidectomy, Sindhuja?
In radical
No, if it is
parotidectomy,
if it has involved the parapharyngeal space, what will be the complaint of the patient again?
dysphagia will be there, ma'am.
You said there is no dysphagia here.
Yes, ma'am.
You understand? So you should think. Okay, you
Yes,
included parapharyngeal space, but then here the patient gives no history of dysphagia. That you should have in mind also.
Yes, ma'am.
Got it?
Yes,
Yes,
ma'am.
continue. Sir, ask for something now.
Sir, in radical,
What are the
we
structures
will
that you
remove
will
the
remove?
facial nerve also, sir.
Facial
No, sir,
nerve,
what about the
okay.
role of MRI? We have not spoken about MRI.
MRI it helps mainly in the to know the neural involvement, ma'am. But in this case,
In
there
this
is
case, is
already
it necessary
established
or not?
neural involvement is there.
In this case, it is necessary or not, MRI?
No, ma'am.
Why not? Nerve is involved.
Now involvement is already established, ma'am.
Good. So,
MRI is not indicated.
okay. So the most important thing here then is
CT.
CT. Okay. So before involvement, an MRI will be useful.
Yes, ma'am.
Yes. Now that it is involved. Yes. You
ma'am.
already know that the nerve is involved.
Involved.
Okay. Continue.
The radical
Continue.
What are the structures you are going to remove in a radical?
Right.
superficial and the deep lobe along with the facial nerve.
That's all.
and leave the patient like that?
You have to take the fascia also, sir.
Which fascia?
Parotid along with the deep cervical fascia inserting the
So you're not
gland, sir.
studied that in depth.
Dr. Sindhuja, sorry, Doctor, sorry. What about lymph nodes? How can you be sure that there are no lymph nodes? Will you address them with T4A? Will you have to address the lymph nodes?
Yes, sir.
What will you do about that?
You can go for if there is nodes are there, we have to go for radical neck dissection, sir. And
No. I mean,
N0
you've got
also.
no nodes. Look, you said no enlarged cervical
Yes,
lymph
sir.
nodes.
In N0 also there is occult
Right.
occult positive
So what
nodes
do you
may
do
be
about
there.
that?
So yes, sir. Radical neck dissection can be done, sir.
You go in straight for radical neck dissection and enroll for radiotherapy here because it's got a nerve
N0
involvement too.
N0 nodes, you will go for a radical neck dissection.
Radiotherapy will be given, sir.
N0
Adjuvant.
nodes. Okay. Can you get the selective neck node dissection?
Sir? Lateral neck dissection can.
Selective neck node dissection. When you have a N0, when you are not showing the clinically or by any means, you are showing there's no node, you can only enough the supraomohyoidal dissection. There's no D.
Yes,
Or you must say comprehensive neck node dissection. Don't use the
okay,
word neck node dissection. You can use comprehensive neck node dissection, which you can decide on how you are going to do that.
Okay.
So are you going to take the deep lobe also here?
Yes, sir.
Why?
Deep lobe involvement is also there, sir.
How do you know?
In inspection by bimanual palpation, deep lobe involvement.
Sir already said you're not
Said no.
supposed to say bimanual.
Sir. So by digital,
Also, it
by
is always an
inspection also
inspectory
there is
finding. You cannot put your finger in the tonsillar fossa.
yes, ma'am. By inspection also there is a suspicion of deep lobe involvement, sir. And also there is obliteration of the retromandibular grooves and lifting of the lobe.
It has nothing to do with the deep lobe or retromandibular.
That imaging also showed involvement of the deep lobe.
Imaging, fine. I agree on that. Only the imaging you can find out. But clinically, you said there is no bulge, nothing,
Yes.
there is no swelling. Okay. By the imaging, you are confirmed the deep lobe is there. So you are going to do the radical parotidectomy.
Parotid, total radical parotidectomy.
So what will you do when you are cutting the facial nerve?
Grafts can be given, sir.
What graft?
Greater auricular nerve graft.
No, what type of graft? Why do you want to cut the facial nerve?
After there is nerve involvement as there, sir.
It can be compression. See, recurrential nerve and the facial nerve, we will try to preserve the nerve as much as possible. Because both the further treatment can, even if it is a small infiltration, if you can remove the nerve intact, it is always a required one. Because once you cut, it is a irreversible damage you are going to cause, and a lot of other procedures you need to go. But if you can preserve the nerve, even if there is you are not able to do the microscopic free, but your further treatment, radiotherapy can able to serve.
Yes, sir.
Okay, you do the not nerve sparing, but you are cutting the nerve and doing the.
Yes.
So you have done the surgery for this patient or not?
Not yet done, sir.
What are the complications of parotidectomy?
So following parotidectomy, the patient may go for a Frey syndrome, fistula formation, or a
Be a little louder.
The patient may go for Frey syndrome and flap necrosis and fistula formation, a seroma formation may be there.
Who is Frey? F-R-E-Y. Who is spraying? Any idea? Pathologist. He or she spray. Any idea? She. Madam. Pathologist, madam. Okay. What is spray syndrome?
So it is due to the injury of the auriculotemporal nerve, sir. There may be aberrant innervation of the secretomotor fibers as a parasympathetic fibers to merge with the sympathetic fibers that supplies the skin and the sweat glands over the parotid region, sir. So whenever the patient is, there will be gustatory sweating, sir.
Okay. How will you avoid spray syndrome?
By creating a thick flaps or placing an artificial membrane or a temporal flap in between the skin and the underlying parotid region, we can avoid it.
How will you
Yes, sir.
manage?
So we can give drugs as botulinum, sir, or antispirants like aluminum chloride may help.
How will you deal with the parotid fistulas? What are the two types of fistulas? One is glandular and another one is ductal.
External, yes, sir. Whether the
Ductal.
opening is through the skin or to the oral cavity. If it opens into the oral cavity, we no need to intervene, sir.
What is the pathology of Frey syndrome?
Injury of the auriculotemporal nerve causing the aberrant regeneration of the secretomotor fibers to the sympathetic ganglion, sir.
What do you mean by first bite syndrome?
Sir, the
First
patient will
bite.
experience pain during the initial time of chewing, sir. After that, the pain will be relieved.
So what is the reason for that?
Not sure. Great rod.
That is a sympathetic nerve involved.
Okay.
This is mainly a parasympathetic.
Parasympathetic.
What about the graft? You were talking about the graft. Which graft you are talking about?
Most commonly, we are using greater auricular nerve grafts now.
But in malignancy, even that is involved, you know.
We can go for sural nerve graft or cable grafts.
So you can go for sural nerve graft, right?
Yes, sir.
Okay, continue. Continue, done. Sir, anything else post-operator?
Yeah, she has presented very nice, madam.
No, how post-operative, sir?
Yeah. So, okay. List the other
What are the
complications.
implications?
Okay. Sorry.
Yeah.
Dr. Sindhuja, you have
Yes, sir.
this iodine test for Frey's syndrome. What is this iodine test?
So the starch iodine test, sir.
Starch iodine.
The starch iodine paper will
What
take,
is starch iodine test?
Yeah, go on. You?
sir,
First you
What
have
is
to
this
apply.
iodine test?
over the parotid region, sir, iodine. Then for the starch, we have to load it with starch.
No, hang on. Just tell me. Come again, please. Something. Speak loudly, please.
The iodine patch is kept over the skin,
Okay,
over the
you
parotid
paint
region,
that
sir.
area with iodine.
I did.
Yeah. Let it dry. Then what happens?
Then we have to give starch loaded orals to the patient, sir.
Give starch loaded
Orals.
food.
Yes, sir.
No, you don't do that.
Patient is given to eat starch.
No, it's not given to eat. No.
Then what do you do? You
Powder.
sprinkle
We
starch
have
over
to
that.
place it over the
Yeah, you sprinkle starch over that
starch
iodine area.
over
Then what happens? Then what do you
there
do?
will be a color change on
No,
chewing,
it won't change color on its own. You ask the person to suck a lemon or take any food. Then what happens?
There will be sweating over that region. Sir.
So what happens in that if there's sweating? That sweat will dissolve that starch and make it react with the iodine. No, the dry iodine paste and all that form a solution, they react with starch and it turns blue, right? So this is the basis. What are the other complications? Quick, the 5 Fs.
Ray's syndrome, fistula formation, flap necrosis, fluid collection, seroma, sir.
Unfreeze, of course. So fistula. How do you manage a fistula? Quick. I think you just got a couple of minutes now.
Sir, if the fistula opening us into the oral cavity, we no need to intervene, sir. And if it is externally also, within 6 weeks, we can manage it conservatively, sir.
And when do you have to intervene?
When the tract is mature, that is more than 6 weeks.
So if there's persistent saliva drooling from the coming out from the fistula.
Yes.
Okay. So I think she's done well. Professor Prabhakar.
Yes,
Ma'am.
sir. I'm having last 3 questions to you. How will you trap the patient? What is the position of the patient? What is the name of the incision for parotidectomy?
The incision we use is modified layers or lazy sessile incision, sir.
No, first, what is the position? How do you prep and then the incision?
Yes.
What is the position?
A supine position with the head tilted towards the opposite side. Reverse Trendelenburg.
And
Reverse Trendelenburg is
Head flexed or just extended 15 degrees? And why?
extended, sir.
Extended. Why? To drain the venous blood. Otherwise,
Yes, sir.
venous
Venous congestion, to avoid venous congestion, we'll put the patient
so head
as
up,
Trendelenburg
30
also,
degrees
sir.
head up. Now draping.
draping.
We have to expose the face also, sir, to know the intraoperatively if there is any nerve injury
No,
means
don't
we can,
expose the
or
whole
if we are
face. You
doing
can't.
nerve monitoring.
Dr. Sindhuja,
sir.
you don't have to expose the whole face. You have to expose the areas where the facial nerve innervates.
Yes, sir.
So the
Eyes
eyelid,
and
the nose, the labia, the angle of the mouth, all that.
yes.
Okay.
Yes.
And now the incision.
Modified layers or lazy sessile incision, sir.
So what is Blair's? If there's a modified Blair's, what is Blair's?
So modified face, there's a sharp angulations are getting avoided, sir. That's why it's called as lazy sessile incision, sir.
So what is Blair's incision? If there's modified Blair's, there must be a Blair's incision also.
The angulation below the earlobe, there will be sharp angulation, sir.
No. Blair's is that it is run parallel to the facial nerve. Okay.
What is a
Modified is this one.
facelift incision then?
Yeah.
Is there anything called facelift incision? Facelift.
Especially for women, we don't give this modified Blair's also, give this facelift. Yes. So
Yes,
ma'am will
sir.
be.
Thank you.
Yes.
For this case, will you do any adjuvant therapy?
Radio.
Yes,
No,
sir. It's a T4 tumor, so we can have to give adjuvant radiation.
What adjuvant therapy?
Adjuvant radiotherapy. Sir.
Okay. Is there any role of any other chemotherapy or targeted therapy?
Targeted therapies, there are some roles like trastuzumab. These drugs have been used. Sir.
Okay.
Yes, sir.
Any measure to prevent Fraze syndrome, Dr. Sindhuja? What care will you take to prevent Fraze syndrome?
So the flap should be made thick, sir. Positioning of any grafts like temporal graft or any artificial membranes in between, sir. It may help us to prevent the Fraze.
One technical hint which was given was when you operate male patients in parotid, make sure that the hair follicles are not seen on the inner aspect of the flap, and the skin flap thickness is enough. You usually do not consider the thickness in our different physic patients. So if you are operating few male patients, make sure that the skin thickness is such that you don't see the hair follicles at all on the inner aspect of flap. And similarly, such practice should be applied, remain close to the parotid gland and keep adequate flap thickness.
Yes, sir.
Shall we finish with this, sir?
Yes, go ahead.
Yes, madam.
You are using the
Yeah,
mic.
you did it well, Sindhuja.
You are using the mic, holding it near the mouth. Is it that you are talking that?
Yes, sir.
That
Wired
gives a
edge.
little different picture view. Huh? No, that should be avoided.
Okay, sir.
That you are presenting
You want to ask something? Sindhuja, which branch you would like to save out of the 5 branches which are there in parotid surgery?
Sir,
Most important branch of
Most
fish.
important.
this the marginal mandibular hernia, sir. Prevent the
Right.
deviation.
What if the
No,
face is
sorry, sir. We have to prevent the ptosis, sir, because the
Yes.
patient have to use
eyes?
drop.
So which
Exposure
branch you are going to save?
keratitis may occur, ma'am. So we have to prevent that. So
Which branch
zygomatic
is that?
branch should be preserved.
Zygomatic has to be saved. You know?
Yes, sir.
Now, if there is injury to the facial nerve is there, you can either tackle it at the time of the operation,
Yes, sir.
or you have to tackle it later on. So what are the various things you are going to do for the facial nerve injury afterwards?
Afterwards, we have to ideally correct within 1 year, sir, or within 6 weeks. It's a neuroplasia. We can give steroids, sir. Even if it's not resolving, even after course of steroids, we have to go for nerve repair, sir.
No, it's only the nerve repair you have to do for the facial nerve injury, or you can do other techniques also. Which is the most worrisome after the facial nerve? It's the eye problem which
Eye
is
problem.
there.
Yes.
So what you can do
So
for
we
that?
have Dacro.
Hmm?
Tarsorrhaphy should be done, sir.
So which tarsorrhaphy, medial or lateral?
Sure, sir.
Which tarsorrhaphy you will do, lateral or medial?
Lateral tarsorrhaphy.
You have to do the lateral tarsorrhaphy, you know? Yes. What are the other dynamic procedure or a dynamic procedure you have to carry out on the facial muscles in case of facial nerve injury? Can you hinge the angle of the mouth so that there is no drooling of the saliva is there? Well, these are the 2 most important things. You know? One is the eye problem and second is the angle of mouth problem which is there.
Yes.
Okay.
You didn't mention about the occupation of the patient. Is it important?
Yes, ma'am. Radiation exposure is important.
That's all? Any chemicals?
Sarcoidosis.
Sarcoidosis.
What did you say? Silica dust or
Silica
sarcoidosis?
dust.
What did you say?
Yes, ma'am.
Or nitrosamines. Okay. So you
Yes,
should ask whether she worked in some chemical factory. She could have worked in a chemical factory or something.
Yes, ma'am.
Right?
Yes, ma'am.
So that is also okay. So shall we stop with this?
Recently, it has been found that a hair dye, it also produces parotid malignancy. In this region, if you dye with the black dyes and all, it can produce malignancy of the parotid. That issue also you should ask. Okay, right, good.
Okay, sir.
Okay.
Thank you.
Okay. Yeah. You did it well done.
Thank you.
Yeah, very well done, Dr.
Yes, sir.
Sirisha. Very interesting.
Almost
Shall we
all
go to the
questions
next?
are answered, except that the parotid duct opening mark, second molar tooth or third molar tooth.
Second
Please
molar.
tell.
So the entering, I think the entry that she made a mistake. Right, Ra?
Yes, sir.
Okay, right. Good.
It is good that students do mistakes here, I think. Everybody can improve.
Yes, sir.
Some mistakes are bound to happen. Well done.
Thank you.
Okay, we can go to the next case.
Taking questions, Dr. Sindhuja.
Nice, sir. Thank you.
Doubts to be clarified.
No, sir. Almost everything is
Prabhakar sir, you are
clarified.
telling something. Sorry, I interrupted.
No, sir.
Fine. With faculty's
Thank you
permission,
for
I
the
call this
opportunity,
case
sir.
discussion a close. Sindhuja, I can stay back for the second discussion.
Yes,
It's
sir.
a
Sure,
case
sir.
of general hernia.
Yes, sir.
I thank Dr. Hitesh sir for kindly permitting Dr. Vedant Shah for presenting this patient. Dr. Vedant, can you share your PowerPoint? Sindhuja, you please unshare your presentation, please.
Hello.
Good evening, sir.
Sharing is not possible, sir.
1 second, 1 second. Dr. Sindhuja? Yes. Please go ahead, Dr. Vedant.
Yes.
Yeah. Good luck, Vedant. Please share your PowerPoint. Please make it to full screen, Vedant. Go to the first
Yes.
slide. Please introduce yourself, your unit chief, head of the department, and start your presentation. Faculty, please take over.
Good evening, sir, ma'am. I will be presenting a case on Incisional hernia. My HOD is Dr. Asit Patel, sir, and my HOU is Dr. Hitesh Andaria, sir. A 54-year-old male patient, resident of Ahmedabad, working as a rickshaw driver, came to surgery OPD with chief complaint of swelling from the previous cassette since 1 year. Patient was relatively asymptomatic before 1 year. Then he noticed swelling over previous scar site, which was insidious in onset and gradually increasing in size to current size. No history of pain, fever, redness, vomiting, nausea, constipation, or chronic cough, or any discharge. No history of blood transfusion. No history of regular or long-term drug intake. History of previous surgery with open appendicectomy 3 years ago, after which he developed enterocutaneous fistula and was operated after 3 months for exploratory laparotomy, plus enterocutaneous fistulectomy, plus ilioileal resection and anastomosis. After which wound was infected in post-operative period and was undergoing dressing for the same, and secondary suturing was done after 3 weeks of surgery. Patient is a known case of diabetes mellitus since 10 years. No significant family history. Patient is taking mixed diet, has adequate appetite, unaltered bowel and bladder habits, unaltered sleep pattern, and is a chronic bidi smoker since 30 years. So this is the picture of the swelling.
Go back to the complaints and history. Swelling from the previous scar site. I don't even know where.
Anterior abdominal wall, ma'am.
In the abdomen.
Yes, ma'am.
Okay. The next one.
You have to mention that in the abdomen.
Yes. Yes, sir.
Is it a swelling from the scar or swelling through the scar, or what do you?
Swelling at the previous scar site. The skin above the swelling was having the scar above it.
Any other swelling can happen over scar site? This is what the question was.
Yeah.
Yes.
Uh,
Yeah, it is.
And how will you differentiate it? This is what the question meant, right, sir?
Yes.
Okay, so there may be a abscess formation, SSI, or an speech-kind
That's
granuloma.
scar. Already a scar is there. Now we are not talking about SSI and all.
Okay.
The patient comes to you after 1 year, some problem in the scar site. What are the other problems?
Yes.
There may be strangulation or
No. One thing which you are with any other pathology or any other disease. This is what sir is asking.
Okay. You heard of keloids, hypertrophic scar?
hypertrophic scar, yes.
Okay.
So,
So, have you tried to differentiate it in history?
Not
Yes, sir.
because when you say it's a swelling, and what kind of things which is meaning it is not it is swelling over the it is not the swelling over the scar. This swelling is
Right.
coming from the abdomen.
Right, sir.
So it is something is coming out and going. Is it reducible?
Yes,
Yes,
sir. It
this
is
is what.
reducible.
So that kind of thing you are not putting it. It's just
Maybe
they
it will be
say
at
this
the
is swelling.
scar site.
Yes.
Oh, instead of saying over the previous scar site, you can say at the scar site.
At the
Scar.
scar, sir. Okay.
That would have been
And
better.
it increases on straining, standing, it reduces. This is what you should say, so that
That has
the,
to be said.
yes,
Hmm.
it is mandatory in uncomplicated any hernia.
Right.
Okay, go ahead. And this when you say this size, current size in a simple statement, it will not give. So what we want to say is a chief complaint is why the patient has come to the hospital. Patient developed swelling. Even I think as a postgraduate, even if you say it is a hernia like swelling, and nobody is going to object to you. And
Right.
put that, and it is progressively increasing in size or something you can put in. No, we expect the postgraduate to go not beat around the bush, to
Okay.
give the almost the good way of presenting. Okay, go ahead. No, no,
Yes, sir.
he
Next,
underwent surgeries, no?
Yes,
What?
sir. Patient has past history of open appendicectomy 3 years ago, after which he developed enterocutaneous fistula and was operated for after 3 months for expiratory laparotomy plus enterocutaneous fistulectomy plus ileoileal resection and anastomosis. After which the wound was infected in the post-operative period and was undergoing dressing for the same, and secondary suturing was done after 3 weeks of surgery.
Why you guys elicited the history of blood transfusion in a case of swelling at the previous scar site? Is there any relation? In what way you can correlate blood transfusion?
No, sir.
Huh?
Why is it coming first?
Oh, the first sentence is no history of blood transfusion. Okay.
History of
even the history of scar is missing. You could have said that appendicectomy was done by which scar? Is it from the same scar, or there are two scars? This is what the patient can give history. If you have mentioned ileoileal resection anastomosis, patient would have definitely said that I was operated for appendicectomy by oblique or incision or like that, and laparotomy was through different scar. This also can be added. Should be rather.
Yes.
yes, sir.
Verbalis incision or a low midline incision? Which incision? 3 years back, the patient has undergone open appendicectomy. Any idea? Whether
Open appendicectomy was done from a separate scar and
So there's a swelling in which
from
scar we don't know.
okay
it was done
from
as
the
an emergency
midline laparotomy scar.
Vedan Shah, it was done as an emergency procedure or an elective procedure, open appendicectomy 3 years ago.
It was an emergency surgery, sir.
Okay, immediately they have done the surgery.
Yes,
In your college, Narendra Modi
yes,
college?
sir.
Yes, okay, right. After which he developed intracutaneous fistula. Why?
Yes, sir.
What was the reason?
Must be they operated for an appendicular mass.
Appendicular. Okay.
Okay.
Sir is asking, Professor Jaina sir.
Did they give the appendix specimen to the patient?
Yes, ma'am.
So appendicectomy was done.
Yes, ma'am.
Okay.
What was the indication? Appendicitis or appendicular mass or appendicular abscess?
Appendicular abscess was most likely, sir.
For appendicular abscess, you have opened the abdomen.
Yes, sir.
Okay, as an emergency procedure.
Yes, sir.
Okay. Go ahead. Okay. So now what is the main complaint, patient?
Patient had complaint of swelling, sir. No pain, no fever, no redness, and no complaint of vomiting.
It's something just like a swelling. Just the lipoma is
Why,
also swelling.
why patient has come to hospital?
Why he has been? They don't call it as a swelling and come into the hospital. What is happening when she coughs and he strains and whatever it is?
Yes, sir. The cough impulse was present, sir. Expansile cough impulse. So when the patient was an auto rickshaw driver, sir.
The picture you
Yes.
shows a lot of abdomen is loss of domain and coming out. So
Yes, sir.
she has any problem with an appetite, any problem with the bowel habits?
Yes, sir. So the daily activity was hampered. Patient was a auto rickshaw driver, sir.
No problem with the bowel habit and other
No,
things.
sir. No, sir. No problem with the bowel habit, sir.
Then why did he come this time?
He was having a problem in daily activity. The daily activity was hampered as he was a rickshaw driver. So
And after the exploratory laparotomy, was he advised to change his job, lifestyle modification?
yeah, yes,
Are you
ma'am.
supposed to give him instructions or advise him?
Yes, yes,
Was
ma'am.
it done?
Yes,
Did
ma'am.
you elicit that history whether it was done or not?
No, there's no history of whether it was done or not.
You never asked.
Yeah.
Is it important?
Vedant, sorry.
Yes.
Yeah. Vedant, in a
Yes, sir.
case of incisional hernia, biohistory, you have to tell us what was the factors which led to it,
Yes, sir.
right? Whether he has had any complications with that hernia or not.
Yes, sir.
Are those factors which were the cause of primary hernia, are they still persisting? And whether he can do a surgery safely, whether it's a single defect, multiple defect, whether he can do a surgery safely without giving him an abdominal compartment syndrome. So biohistory, all this thing has to come, including examination, of course, but biohistory, all this thing has to come out, right? In a sequence. Whether it's incision hernia, what was the cause, what were the factors, did he have any complications, are those factors persistent, does he require surgery now, right? So
Right.
that's how you have to go about it.
Okay, sir.
Should we
As
go
I
to the
mentioned, sir,
examination?
You can go for examination.
patient is examined after receipt of informed consent in a well-lit and well-ventilated room with proper exposure. Uh, patient Patient is conscious, cooperative, and well-oriented to time, place, and person. The weight of the patient was 91 kgs and height was 5 foot 6 inches. So the BMI was 32.6. 32.6. On vitals, temperature was normal, pulse 76 per minute, BP was 136 by 86. No pillar, icterus, nail clubbing, lymphadenopathy, pedal edema, or cyanosis noted. Systemic examinations findings are non-significant. On inspection, I used well-defined abdominal swelling of approx 20 into 15 centimeter present in the midline, extending from approx 5 centimeter below the xiphoid process to 5 centimeter above pubic symphysis. A scar was of previous surgery seen over the swelling. Expansile cuff impulse present. Skin over the swelling appeared thinned out with no any redness, dilated veins or pigmentation, and no visible peristalsis.
No pigmentation?
The skin was normal except for the scar side. The surrounding skin was normal.
Have you got a picture, Vedant?
Yes.
Okay.
The
So
surrounding
the
skin
two
was normal.
scars.
Yeah. Yes, sir.
Yeah,
And
go on.
Vedant,
Yes,
if it's going to be 10 into 10 centimeters, what are you going to say? Moderate size? So are you supposed to use all these words?
No, ma'am.
Huge.
No, ma'am.
So that is why we are mentioning about the size. Then why do you want to
Size.
talk about huge and all that, right?
Right,
We
ma'am.
have dimensions. That is more than enough.
Right, ma'am.
Okay, good. Continue.
On palpation, all inspected findings are confirmed or positive. No tenderness or local rise in temperature. Expansile cup impulse palpable over the swelling. Size of 20 into 15 centimeter. Shape globular. Surface was smooth, margin regular. Firm in consistency and reducible. Facial defect of 18 into 12 centimeter was palpated. Other hernial orifices were intact and no other palpable lump was present.
Yeah, go on.
On percussion, no shift in dullness or fluid seal was seen.
You are able to do it?
Uh, Sorry, ma'am.
You are able to
In a
perk it?
case of right, in a case of incision hernia, is it possible to do this?
Ah,
And why have you done it? Look, if there's such a large hernia, you can't do shifting dullness here unless the abdomen is
Right.
absolutely tense. Or I
Right.
mean, there's a lot of fluid. I'm not absolutely a lot of fluid there.
Right.
Okay. In a hernia, it will go into the sac. You can't do it.
Right, sir.
Yeah, go on.
On auscultation, bowel sounds were heard and normal in frequency. This is the
No,
sonography of the. Yes.
no, hang on.
Right.
Bowel sounds are heard in normal in what do you mean normal in frequency? इसका कोई मतलब होता है? Do you write all this in your so you, look, Vedant, you're supposed to tell us and do whatever you do in the wards.
Right, sir.
Do you do this in your ward? Normal
No,
frequency
sir.
of bowel sounds. Ever in my life, I've not heard of it.
No, sir.
Then why do you just write bowel sounds for the auscultation?
Yes, sir.
Okay, we'll discuss it. Go on, next slide. No,
So
we
these
don't
are
want your
the.
ultrasound here. We don't want your ultrasound here. We want you to complete your examination.
Anything missing in examination? Abdomen.
Look, you've not mentioned about organomegaly,
Sir, yes, sir. No other
right?
palpable lump or organomegaly, sir.
No other lumps. Is there a single defect, multiple defects, right?
The single defect
You have
of
not
18 into
examined the
20.
spine, per rectal examination,
External genitalia.
can
genitalia,
you show
external
me the
genitalia.
picture?
Any
Show me the
problem in its
picture,
maturation?
Vedant. So you think what is it? The surface is smooth. Then what is protruding out through this hernial defect?
So, ma'am, omentum and bowel both were protruding
So it
out.
is
You were able
important
to
to
palpate that?
Yes, ma'am. Sorry.
The skin was thinned out and you were able to palpate.
Yes, sir. Yes, ma'am.
Yet you want to call the surface smooth.
Vedant, what is most important is that we have to know the content of your hernia.
Right, sir.
Your examination, you have not brought that out. What does your hernia sac contain?
Omentum and bowel were both present, sir.
How do you know it's bowel? How do you know it's omentum?
So there was firm consistency, dye consistency of on palpation.
Consistencies are. Can you hear bowel sounds in that her sac?
Yes, sir.
So mention it. Where is it mentioned that the sac you can see the bowel, the peristalsis. You can hear the bowel sounds.
You can
Vedant, देखो
even
मेरे पास,
palpate.
right? You
Uh,
you think you're going to operate on this patient. Is it important to know whether the gut is inside there or not?
yes, sir.
Why? Because when you're going to operate, you may damage the gut, and if when you replace it, gut has got a huge volume, right?
Right.
It will cause some sort of compartment,
Compartment.
right?
Right, sir.
Yeah. Have you examined the external genitalia?
Yes, sir.
You have not mentioned it.
Right.
Is it important? Look, you have to rule out all the. He might not be having any problem then. He could be having a problem now. You get me? 3 years. So all that your examination is incomplete. You get me?
Right, sir.
You operate on this guy and he's training on his urine and foot. Your thing gives way. He comes back within a month. I spent 1 lakh rupees on my surgery and I got it again back again. You get me? Yeah.
Yes, sir.
Okay. Let's get your finish your examination. What after what after your ultrasound slide? Do you have anything to
No,
talk
sir.
about?
No, sir.
Have you have to do a EHS classification?
EHS classification I have written, sir.
Where have you written? So yeah, that's what I'm asking you.
Right.
That. So why did you show
Yes,
us the
sir.
ultrasound report before?
Yes, sir.
Okay, what does M3W3R0 mean?
Sir, in EHS classification, sir, M1 is subxiphoid. The M2 is epigastric. M3 is umbilical. M4 is infraumbilical, and M5 is suprapubic, sir. So the swelling lies in the umbilical region, centered. So M3, W3 means the width of the defect, sir. So it is more than 5 centimeters, sir. And R0 is there is no recurrence. It is not a recurrent hernia.
Good. Good. Okay. So yeah. So now what do you do about it? You got this place. So please, Professor Prahaka, ma'am, Sir Professor Jalal, please.
Incisional hernia. What is the difference between incisional hernia and ventral hernia? Vedant, both are same.
Sir, ventral hernias can be primary and secondary. Incisional hernia is secondary to a previous operative history. In ventral hernias, incisional hernia is a type of ventral hernia, but
Which
it is a
hernia,
secondary. Yes, sir.
which hernia will not have any sac? Ventral
Sir,
hernia.
epigastric hernia will not be having any sac, sir.
Epigastric hernia of linea alba.
Yes, of linea alba, sir.
Okay. What is the expression of EHS?
European Hernia Society, sir.
European Hernia Society.
Yes.
Why do you say it's an uncomplicated? What are the complications you can expect in a case of incisional hernia?
So it can get strangulated or obstructed. Strangulation when the bowel gets necrotic and the uh,
So first
emergency.
strangulation and then obstruction, is it?
No, sir, ma'am. First obstructed. Both are different, ma'am. In
Then
obstruction.
you should tell it in that order only.
Okay, ma'am.
Mm.
Oh. Obstruction is when the blood supply is intact and there is a problem in dynamic.
Irreducibility, obstruction,
Yes, yes, sir.
and then your strangulation.
Strangulation.
What is the difference between compressibility and reducibility? In your case, it is a reducible swelling. Huh?
Yes, yes, sir.
It's a reducible. Now, what is the difference between compressibility and reducibility? Is there any difference or both are same? Vedanta.
Sir, in compressibility, if there is a bowel present in the hernial sac, it may be compressible but not reducible.
Which one? Tell me one example for compressible swellings. Tell me one example for reducible swellings.
Like, sir, cystic hygroma is a compressible swelling, sir.
Which one?
Cystic
Cystic
hygroma, sir.
hygroma.
Cystic hygroma is a compressible swelling. There is no need
Yes,
for
sir.
any opposite force for the reappearance of the swelling. If you press and release, it will automatically come. But in a case of hernia, you have to ask the patient to cough. Then only it will come. Otherwise, it will
Yes,
not come.
sir.
So it's a reducible. This one is the compressible. Okay.
Come.
Yes. What would be the reason for the hernia in this particular patient? What are the causes in this
Sir,
particular patient?
sir, there is a surgery related complication. Surgery
You
related
might have done
complication, and
lot of
patient.
appendectomy patients. You might have done a lot of appendectomy in your college in Ahmedabad.
Yes,
But
sir.
why particularly this patient is having hernia? What would be the reason?
So patient is a known diabetic, sir, since 10 years, and a weed smoker, sir. Smoking, addiction of smoking since 30 years.
Smoking, huh? Rickshaw
Yes, sir.
driver.
Yes, sir.
Mhm.
That's all.
And also, sir, ma'am, obesity was present. Patient is overweight.
What is his
As we
Patient
job?
saw,
is obese.
What is the main reason in history?
there was a wound infection, which was which can be the
Fistula
reason for fistula formation, and
and then
wound infection in the post expiratory laparotomy, sir, post operative period.
fistula to have malnutrition, right? And these all
Yes.
factors can together work in.
Coming to man,
Yes,
intracutaneous fistula after appendectomy.
sir.
For
Sorry.
all cases, you
The BMI is
second.
more, yet you want to call him nutritionally deprived.
Yes, sir. Yes, ma'am.
How do you manage
Yes,
endometritis?
Veda.
Yes, madam.
Yes, ma'am.
He is nutritionally poor in spite of being obese.
Yes, ma'am. Malnutrition can be both, ma'am, un undernourished and overnourished, ma'am.
So he is overnourished malnutrition.
Yes.
Huh?
What are the differential diagnoses? One is incisional hernia. What is Spigelian hernia? Have you ever heard of that terminology?
Yes, sir.
Vedan?
Spigelian hernias. Yes, sir.
What is Spigelian hernia? What is Spigelian belt? What is Spigelian fascia? Where it is present in the anterior abdominal wall?
So it can be present uh, above the arcuate line and below the umbilicus in Spigelian fascia. Uh, linea seminularis, sir. Uh, at the seminularis, below arcuate line, there is the fascia, Spigelian fascia. When the hernia occurs through the Spigelian fascia, it occurs from there. It is lateral to the rectus abdominis muscle, sir.
What is the other name of this Spigelian hernia? Interparietal hernia. Interparietal hernia. What is
Interparietal.
arcuate line? It's present.
Yes, sir. Sorry.
What is arcuate line? Where it is present?
So
How it is
it is
formed?
present. It is present below the umbilicus when there is a deficiency of posterior rectus sheath, sir.
Absence of a posterior rectus
Posterior
sheath
rectus sheath.
below the arcuate.
Yes.
Okay. Okay, how do you manage this patient?
Sir, patient was taken for elective OT of transverse abdominis release, sir, and retrorectus mesh plasty.
No, but should you do surgery for this patient first of all? There is no irreducibility, no obstruction, no strangulation. The patient doesn't give any history of constipation. Did you talk about bowel habits?
Yes, yes, ma'am.
Normal bowel habits?
Yes, ma'am.
Did you mention?
Yes, ma'am. I have mentioned it.
Okay, then why do you want to operate?
Uh, as it was having a problems in the daily activity, ma'am, and patient was insisting in operative management.
Oh, patient wanted surgery. That is why you want to do surgery for him.
No, ma'am. It can complicate in the future, sir, ma'am.
So anticipating future complication, you want to operate now. What future complication you are anticipating?
Strangulation or obstruction, ma'am.
Okay. So
Or
again, you're saying strangulation and then obstruction.
sorry, ma'am. Obstruction and strangulation.
Okay. So why should the patient go for obstruction first of all? It's such a huge defect,
Yes, ma'am.
Then, so it's not going to be irreducible. There's not going to be any obstruction. And if all these are not there, the patient definitely will not go for strangulation also.
Right, ma'am.
Then why do you want to operate?
There may be, ma'am, post-operative adhesions which can cause obstruction for in the future.
Anything else looking to the skin of this swelling? Any other reason can develop?
It can thinning of the skin
Yes,
was
that is the
present
most
throughout.
common complication.
Right.
Yes, the abdominal wall is thinned out. Loss of
Yes,
domain.
ma'am.
Yes, you can
Yes,
just
ma'am.
see the bowel underneath.
And it keeps on increasing in size over a period, right?
Oh,
Eventually,
yes.
it will rupture.
Okay.
Yes. Yes.
Excoriation, yes. That is why.
Yes, ma'am.
Okay. Yes, continue. So you want to operate. Okay. So how are you going to proceed?
Any investigation before planning of the surgery was done, or will you like to get it done?
CT scan was done to for CT scan was done, and for loss of domain to check whether there is loss of domain or not.
You already know there's loss of domain.
Yes, ma'am. But in CT scan we can know that whether there is a single defect or multiple defects.
Does it matter now?
No, ma'am.
You already said it's a huge one.
Yes, ma'am.
Okay. So there is loss of domain. You've confirmed that.
Yes, ma'am.
Okay. Then how are you going to proceed?
Patient was taken for transverse abdominis release repair release.
So you don't prepare the patient for anything?
Suppose this patient comes to OPD, will you operate straight away next day or so, or you prepare? This is what madam is asking.
We will prepare for the nutritional status of the patient and check whether the protein is
You're
proper
always
and
bothered about the nutrition of the patient, Vedant. Okay. Anyway, I think you like the word. Yes. Continue.
and will
What surgery you are going to do for this patient? What's the name of the surgery?
transverse abdominis muscle release and
What do you call?
retrorectus mesh plasty.
What are the muscles present in the anterior abdominal wall? Tell me.
So external oblique muscle, internal oblique, transverse abdominis, rectus abdominis.
What is
And
pyramidal?
will
Right. Okay. Among all these muscles, which muscle you are going to release?
transverse abdominis.
Transverse abdominis.
Yes.
Okay. Which part of the muscle you are going to release? Muscle proper or the sheath covering the rectus, the transverse abdominis muscle?
The sheath coverings the transverse abdominis muscle.
Where?
Uh, from the lateral border, sir.
How the semilunaris line, that is linea semilunaris, is formed in the anteabdominal wall?
Yes, sir. Sorry, sir.
How
Sorry,
semilunaris, the linea semilunaris, how it is formed?
Yes. Sir, when there is it is the lateral border of the rectus abdominis muscle. There is the deficiency of rectus abdominis muscle.
Will you keep mesh or not?
Yes, sir. We will keep a mesh, sir.
Where will you keep the mesh? Where you will place?
Sir, retrorectus, sir. Retrorectus must place, sir.
Over the anterior?
Yes, sir.
Over
Sorry.
the? Where will you keep the mesh in this particular patient?
Sir, in the retrorectus plane, sir.
Retrorectus abdominis muscle.
Yes, sir.
You are going to do that in the open method or laparoscopic?
Sorry, sir.
Can I come in for a minute? Veda,
Laparoscopic.
with
Yes,
this
yes, yes.
hernia, what are the indices you would like to use upon before planning for a definitive procedure? Apart from clinical assessment, it looks like a lot of organ and standing position is out of the abdominal core, right?
Yes.
So we depend like how we are thinking about staging indices in malignancy. Staging indices in malignancy. Hernia indices are also improving. Like you mentioned very clearly, the EHS staging for ventral hernia.
Yes.
Apart from that, what are the indices will guide you whether this patient needs a definitive prehabilitation process or a upfront surgery process?
One is the Tanaka index and Cabernar's index, sir. In Tanaka index, it is the hernial sac volume upon the abdominal cavity volume, which should be less than 0.25. And Carbonell's index is width of the both rectus muscles upon the hernial sac defect, hernial defect.
All right. So with that few background of information, now you have the component separation index, Sabak's index, and other new indices are coming upon. Things apart, you should be able to understand when the patient is in standing position, the amount of bowel coming out, whether the abdominal cylinder will be able to hold the bowel back into the abdominal cylinder. If you find the radiologist says, no, we don't have that much space, then you need some form of prehabilitation procedures. What are the
Yes, sir.
typical prehabilitation in these type of large hernias you would like to do?
Sir, we can introduce, sir, Botox injections 4 to 6 weeks pre-operatively, sir. And
What dose and how many places you have to split the dose? So usually you go up till 150 units. Some people go up till 200 units. Usually
yes,
3 different spaces on either side. So six divide into six. So 40 units per shot per location you give. That's a normal formula. All right. So this can be given generally with ultrasound guidance, where you want to release the transverse abdominal zone, or depending on this looks like a midline. So
yeah,
most of the time what happens is the rectus muscle gets played out. So depending on your radiology images, you understand what happens to the rectus muscle and what happens to the transverse abdominis. You give the Botox at that particular point. Sometimes you may
yes,
need to repeat the Botox once in every 2 weeks, up till 3 times you can consider in all. All right. So what are the other
yes.
methods to improve the peritoneal volume?
Sir, another is progressive pneumoperitoneum, sir.
Can you tell what is the basis of progressive pneumoperitoneum?
Sir, we are stretching out the muscles and the abdominal wall, sir, so that it gets relaxed and can be increasing the cavity size of the abdomen, sir.
Can you
Progressively.
briefly tell how do you do the progressive pneumoperitoneum? Is it an inpatient procedure, outpatient procedure?
Do you do it in the ward or do it in the theater?
Yes, ma'am. Yes, ma'am.
Uh,
It has all the safety precautions of a regular surgery only, right?
yes, sir.
So you have to get the patient prepared, give some amount of local anesthetic medicine when you're placing the catheter, and then the catheter remains in place, right? You send them home. So normally,
Yes,
how
sir.
much of pneumo as a trial you want to introduce on the first time? You have some ml, no? Ml, basis of how much ml you want to give. See, by doing lap cholecystectomy, how much of gas goes in before you reach the 10, 12 millimeters of mercury abdominal pressure? Have you ever seen that? When you do, so you do every list, you do lap cholis, no? Tap procedures, step procedures, and all. So how many liters of gas it holds in the abdominal cavity?
Uh, Around 800 to 1500 ml, sir.
You are giving it too long a range. So usually
Yes.
it can hold, see, an adult normal 60 kilo patient will hold 2.5 to 3 liters, right?
Oh.
So this much capacity it can hold. So in reality, but then it will be very stressful for a patient who's not under anesthesia to hold this much of air. There will be diaphragmatic pressure and patient may not feel very comfortable. So what normally we tell is 1 to 1.5 liters of home air, ideally. We allow the patient to inject by themselves. Patients are very educated. They can inject by themselves.
Yes, sir.
I inject by themselves. And then as much as they tolerate, that's what we tell. Usually around 1.5 to 2 liters, they'll be able to tolerate. Even at the home, they can clean themselves, wash up nicely. And we have the syringe gadget kits where they can inject. We normally don't go by 500 ml, 1000 ml or something. Patient can inject to the amount they can hold it. All right. So otherwise, you can ask them to come to the hospital in a clean, sterile procedure room. You can do the inflation part of it. So a minimum of 4 to 6 weeks of insufflation is recommended. And then you repeat the CT, how much you are accumulated, how much your indices are changed. In the meantime,
Yes,
patient has to be put on some amount of weight loss diet and physical rehabilitation also have to come. We are worried about aerobic endurance alone. We don't, even now people go on to tell strength training is also important. At this point of time, the aerobic component alone, cardio exercise is the most recommended exercise. So 4 to 6 weeks time is the optimal pre-optimization time. Then you reassess, by then the abdominal cylinder gets more capacious. So what is the optimal surgery you would like to plan in these type of loss of domain hernias?
we can go for, sir. Like I said, transverse abdomen is release muscle, release surgery with retrorectal mass plasty, sir.
All right. So I will tell you the signs of large loss of domain surgeries are expanding well, but you are well within very safe limits. Examiner will agree when you are telling you will do a Reeves-Topa approach. Depending upon the laxity and approximation of the midline, you may need to do a limited transverse abdominis release or posterior component separation, either single side or double side. This should be an optimal thing you tell. The examiners will agree. All right. But then if the examiners want to probe you more, what is the most recent technique which everybody is talking about? Still not very prevalent in India. Have you heard something about tissue traction devices? Don't worry. This is a fairly recent technique, but it's there in the market for almost now 3 years. It is called the fasciotense or the tissue traction device. It is like, have you seen Elizarov retractor?
Yes, sir.
For limb lengthening, something like that. The abdominal
Yes.
facial muscular myofascial lengthening can be done on the table, and then you don't need any component separation. So this is called the fasciotense. All right. So what are the
Yes.
typical problem if you have done posterior component separation, you are not able to still achieve the midline closure without tension. What are the other options you have?
The anterior release is
So
also there.
anterior component can also be
Compound
attempted,
separation.
limited one side or
Yes.
two side. The other thing
Yes,
is
sir.
use the sac. Don't discard the sac when you're dissecting. Protect the sac.
Yeah.
Sac can also be used as a bridge for placement of the mesh. All right. Then without doing a Reeve-Stoppa approach, you can do a totally extraperitoneal approach. If you're talking, everybody is talking about the PETEP procedure. Same thing can be done here. Once you cross the linea semilunaris, you have a very ease of peritoneum which easily comes down, and you do a extraperitoneal mesh rather than keeping the mesh on the retrorectus plane. These are the recent advances, and you can also try. There is a procedure called North Carolina's crossover. What you do is one side you go on the retrorectus space, other side you keep on the extraperitoneal space. These are the newer things. I wish you go back and read. But these patients need a very multidisciplinary approach, a comprehensive care plan, and post-operative recovery should be also be monitored very, very carefully. All right. Good luck.
Yes.
Other faculty, please take over.
Okay, what is the type of mesh you're going to use?
Ma'am, polypropylene mesh will be used.
Sure.
Hello. Yes. Sorry, ma'am.
Don't you want to use any biological mesh?
We can use, ma'am, but the patient is socially low economic, so it may not be used, and polypropylene mesh is
You want to use a polypropylene mesh only.
yes, in this case.
And place it in the retrorectus space.
Yes, ma'am.
Are you very comfortable with it? Which one is better?
Ma'am,
A
biologically,
composite one.
yes, ma'am. What?
A composite mesh.
Yeah, combination of materials. Typically, it is a permanent on one side, and another side is a
One
non-adhesive,
side is slippery and the other
Good.
absorbable.
side is sticky.
Yes,
Composite,
sir.
right?
Good. Good. That's better way of answering, right?
Yes.
What are the
Okay,
complications
Prabhakar.
of mesh plasty? What are the last question? What are the complications of mesh plasty? Vedanta.
So in complications, maybe there may be surgical site infection can be present. Mesh migration can be mesh. It can lead to chronic pain if there is a nerve entrapment or infection even. Then recurrence can occur after it. And if we place the intraperitoneally the mesh, the adhesions can be formed. Adhesions can lead to obstruction. Then seroma formation can happen. Hematoma formation can happen.
Hematoma also.
It can occur if but it
Why hematoma
but that
occurs? Why does hematoma occur, man?
seroma.
Okay. Hmm. And recurrence is, you said recurrence, is it?
Yes, no, recurrence can occur after the surgery.
Yes, if you're going to allow him to do again the cycle rickshaw job, he's going to get a recurrence.
Yes, ma'am.
Even otherwise, he'll get.
Yeah.
So what is that strength of the that is regained after a laparotomy?
Madam.
70% of the original strength is recovered after the laparotomy incision.
Okay. Now what about this patient then? Two surgeries, then what happens?
Yes, ma'am. It will again decrease the strength of the
Goes to
muscles.
40 to 50%.
Yes,
That's all. Okay.
yes, ma'am.
So,
Yes, ma'am.
so again, he's a diabetic, and you said he's obese.
Yes, ma'am.
And then what else? What are the comorbidities he has?
He's a smoker, ma'am.
Yeah, he's a
Addict.
smoker. So what promise are you going to give him if you're going to operate?
Smoking suggestions should be there 2 weeks before the surgery and should not continue after the surgery too. Then light activity, no strenuous activities should be done. Maybe lifestyle modification of changing the job, changing the occupation if feasible for the patient. Then weight loss can be advised.
Okay. So Prabhakar sir, anything else?
Nothing, madam. Nothing.
Other faculty, do you have any questions? Vedant, do you have any doubts, ma?
No, sir.
Actually, faculties would
Okay.
like to.
So, but
I like to say sorry to faculties on his behalf, and I will feel sorry for him also, because at last moment, that is again not an excuse, at 5:45 p.m. only he selected the cases from the old pictures and all. He has created this PPT. That is very unfortunate part, because I asked him, all my students, to prepare the case yesterday, but somehow they were not keen to accept the challenge. Last moment, 5:45 p.m. only, when I said that we need one case, he at the gunpoint got ready to do presentation by fetching few of the pictures and history and X-ray CT scan. So that is fault on my part as well. I feel extremely
No,
sorry
no, sir,
for.
Dr. Hitesh, Dr.
No, no,
Hitesh,
sir.
this
Not
is,
for.
it takes a
Sir,
lot of courage to present here, first of all. Anyone who
but
presents has
let me
done well because he has got the
let
courage to present.
yes, let me finish,
So
sir.
he
The
has
problem.
done well. He has done well.
No, no, madam. No, no. I understand. This is not new
Sir,
form for me.
no, sir. He is only a sample for the others to learn.
Exactly.
So, that is what it
Let
is, sir.
let me finish. This platform is not new for me and for my students also. For all students are
Yes,
our students. The problem is they do not practice this in regular ward rounds.
that's true.
Otherwise,
That's true, sir.
this problem would not have arisen. And I have
Sir,
told
no
them,
problem at all.
yes, I understand. I understand. I am a very regular member since almost all 300 days. I have been present at least more than half cases, but they should prepare each and every day a case,
Yes,
clinical case.
that I agree, sir. They should be ready, as you said, at gunpoint, present. When the
Yes,
chief says present, they should present.
yes,
Rattle
this
with
is
it.
the message what I wanted. And tomorrow I am going to ask other two, his batchmates and juniors, that any moment I'll say that
Yes,
today
yes,
you present.
that's true, sir. That's true. Agree.
Was the lesson needed, rather than it is not any, there is no shame on part of him or we or me, but everybody should learn that you should not shy away from presenting on such
Yes,
a
yes,
large
yes. Agreed, sir.
platform. So many faculties are there to teach you, so many have taken so much pain of spending there 2.5 hours of time. Many are waiting for dinner to be finished. So take it very serious, Vedant, and all PGs who are listening today as well as on YouTube. Don't be ready for fast food. Just try to prepare your grains and cut it and then make food for you, and then you will definitely have the best of digestion of your knowledge system. Thank you,
Yes, sir.
sir, for
Okay.
your deliberate efforts to pull him. Thank you very much.
So,
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Kanna sir, Jailan sir, Sahi sir, any other comments from you, sir?
I think
So thank you very much, all of you.
Thank you. Good night.
good night, sir.
Good night,
Good
good
night,
night, sir.
Thank you. Good night to you, Dr. Sindhuja and Dr. Vedant. Thank you, Prabhakar sir and Gayatri
Vedant,
ma'am.
Vedant, take it
Thank you,
positively.
sir.
You will definitely improve.
yes, sir.
All the best.
Good luck to you,
Thank you, sir.
Vedant. Take care. Bye-bye.
I think Vedant
Yeah.
answered whatever I
Thank you, ma'am.
asked.
Thank you, sir.
Sorry.
Yes, ma'am.
You answered whatever I asked, Ben.
All examiners are there to pass you. They are there to pass you. You have to
Yeah,
fetch
yeah,
the
yeah.
hint. You have to fetch the hints.
Yes.
And make it
Yes,
a
all
habit
the
of
best, man.
presenting.
All
Make
the
it a
best,
habit.
Vedant. You did it well. You faced this
Thank
all
you.
very bravely.
Yes.
Thank you, ma'am.
Yes. Yeah. Bye then.
Good night.
All the best.
Good
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 night.
night.
Thank you, ma'am. Thank you. Thank
Thank
you,
you.
everyone. Thank you.
સારું બોલીશ